Common parasomnias found in children are sleepwalking, sleep terrors, confusional arousals, and nightmares. Sleepwalking is a common and benign parasomnia. Almost 40% of all children will sleepwalk at some time. It usually starts between 4 and 8 years old. Adolescents and adults also can experience sleepwalking, particularly if they did so as children. When we see sleepwalking, the eyes are usually open, and although the sleepwalking child may appear to be awake, he or she is actually asleep. They may appear confused or dazed. Also, they may mumble or give inappropriate or incoherent answers to questions. They are often clumsy and may perform bizarre or strange actions, such as wandering around the house or urinating in a closet. In the morning, there usually is no memory of these events. Sleepwalkers commonly have obstructive sleep apnea. Sleep terrors usually are the most extreme and dramatic of the parasomnias and can be distressing to the witness. Approximately 3% of children experience sleep terrors, primarily during the preschool and elementary school years. Sleep terrors usually occur between 4 and 12 years old. Sleep terrors begin suddenly. There will be blood-curdling screams, usually involving crying. Extreme agitation and terror, including shaking, sweating, tachycardia, hyperventilating, and dilated pupils can occur. They may attempt to escape from bed or to fight. They will resist being comforted and become more upset and agitated if parents talk to them and try to calm them down. The child may appear to be awake, but he or she is really asleep. The sleep terror usually resolves quickly, within 3 to 5 minutes, with a prompt return to quiet sleep. Sleep terrors are usually much worse to watch than to experience, and much less traumatic to the child than a nightmare or bad dream. Children who experience sleep terrors commonly have obstructive sleep apnea. Confusional arousals consist of mental confusion or confused behavior during or following arousals from sleep, typically from slow-wave sleep in the first part of the night, but also upon forced awakening from sleep during the night or in the morning. These can be similar to sleep terrors, but much milder. Confusional arousals begin with crying and thrashing around in bed. The child may seem to be awake, but is essentially stuck halfway between asleep and awake. They can be very confused or upset. They will cry or speak without making sense. The event may appear quite bizarre and frightening to parents, as the child can appear to be staring right through the observer. Sometimes the child will yell or scream. Confusional arousals usually are short, lasting about 5 to 15 minutes, but they may last as long as 30 to 40 minutes in some children. It is best for parents to try to resist comforting the child during one of these episodes, since most children will become more agitated. Young children who have confusional arousals often go on to sleepwalk as adolescents. Nightmares are frightening dreams occurring during REM sleep that usually result in an awakening from sleep. Nightmares are very common in children and are usually a part of normal development. Content in nightmares usually differs with the child's age and reflects common developmental issues. Most young toddlers have concerns about being separated from their parents. Children may have nightmares about being lost or having something adverse happen to one of their parents. By 2 years of age, nightmares begin to involve monsters or scary things that can hurt a child. Nightmares are more likely to happen following some difficult event in the child's life, such as starting daycare or a parent going away overnight. They can also occur after a frightening experience like getting lost, getting a shot at a doctor visit, or being barked at by a big dog. Children should avoid scary stories, television shows, or movies before bedtime to help reduce the likelihood of nightmares. A child is typically fully awake and alert after awakening from a nightmare. Unlike sleep terrors, Parental reassurance and comforting is recommended and usually very helpful, although it may be difficult for the child to go back to sleep. It can also be helpful for a parent to talk to the child about the nightmare the next day to see if there is anything bothering him or her. Most nightmares are isolated events with little significance, but if a child starts having them on a frequent basis, an attempt should be made to try to figure out what may be disturbing the child. Restless leg syndrome and periodic limb movement disorder can be idiopathic or secondary. RLS can be a cause of a presenting complaint of difficulty settling or insomnia, and is occasionally misdiagnosed as growing pains when the clinician misinterprets the discomfort and irresistible urge to move as pain, or when the child has difficulty explaining the symptom to the clinician. Primary enuresis is frequent nocturnal enuresis past the time when toilet training should have occurred, with only rare dry nights and no periods of dryness lasting longer than 2 weeks. Secondary enuresis refers to a reoccurrence of bedwetting after a period of several weeks or months of not wetting the bed. Primary enuresis is much more common than secondary. Enuresis can have a differential diagnosis such as inadequate sleep hygiene, sleep-related seizure disorder, sleepwalking, and obstructive sleep apnea syndrome.